Welcome to the 2014 ARC webcast series. This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of AARC. Copyright 2014, all rights reserved. My name is Tim Myers. I am a respiratory therapist, neonatal pediatrics specialist, and Associate Executive Director at the ARC. I welcome you to today's presentation, Asthma Self-Management. Upon completion of this ARC webcast, participants will be able to identify the evidence supporting asthma self-management, discuss the barriers to effective asthma self-management, identify strategies to overcome barriers to effective asthma self-management, and discuss the role of the respiratory therapist in fostering effective asthma self-management. I am pleased to welcome Dr. Shawna Strickland. Dr. Strickland is a respiratory therapist, a certified asthma educator. She is the Associate Executive Director for Education at the ARC and has been involved in programs to promote asthma self-management in rural Missouri. Neither Dr. Strickland nor I have any conflicts of interest related to the presentation. Any use of images or brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis. Dr. Strickland, welcome to the program and the presentation today.
Thank you, Tim. I am very pleased to be here today. And before I get started, if I could maybe see how many people in the audience are certified asthma educators. If you are, click on the little hand icon at the top, raise your hand, or you could click the yes button, the green check mark if you wanted to. Fantastic. There are a lot of people in the room who are certified asthma educators. That's great. What I want to really focus on, and they keep coming in, this is awesome. What I really want to focus on today is disease management, and especially within the context of asthma, of course. So when we bring this up, we talk about disease management a lot, but many times people are asking, what are we talking about? What is the purpose? What does this disease management really mean? What is the point? Why is it important? And why are we talking about it? And honestly, why are respiratory therapists interested in disease management specifically? So here's a definition from the Disease Management Association of America. And I'm not going to read this to you. Obviously, it's on your screen. You can read it for yourself. But I want to point out a couple of things that are important within this definition. The first word I want to draw you to is coordinated. These are not random interventions for our patients. These are interventions that are coordinated with other healthcare providers to make sure that we're directing the care of the patient in such a way that it's going to benefit the overall health and wellness of the patient and improve quality of life. Communication among providers, communication between providers and patient, family and providers is very important, that open communication. And again, this is going to lead to effective self-care efforts, and that's the important part. We don't want our patients in the hospital. We want our patients to stay at home, and we want our patients to be effective in managing that disease process so that they can stay at home longer, decrease their burden, the cost of asthma and the burden on their lives and on the healthcare system as a whole. So before we get too far into asthma self-management as its own animal, let's refresh our memory about the burden of asthma worldwide and in the United States. The Global Initiative for Asthma estimates that as many as 300 million people worldwide suffer from asthma. And an increase in asthma prevalence is linked to the urbanization of communities. That's not a surprise with the crowded living conditions and the pollution experienced by the population in those urbanized communities. Worldwide, asthma accounts for about 1% of all disability-adjusted life years, and that's similar to the disability-adjusted life years of diabetes and liver cirrhosis. So I don't think I'm giving you a big news flash when I tell you that asthma is a huge burden on our society. In the United States, we've had a significant increase in the incidence of asthma. The asthma prevalence in 2001, according to the CDC, was 7.3%. And you can see from this data on the screen from 2012, and you can find that at the CDC link at the bottom of the screen, that the prevalence in adults has gone up to 8% and in children 9.3%. So we do have a significant increase in the incidence of asthma. And at this point, that translates to about 1 in 11 children with asthma and about 1 in 12 adults with asthma. And you can see also on the screen that females tend to have a higher prevalence of asthma than males, and our African American community tends to have a higher prevalence than our Caucasian and Hispanic communities as well. Interestingly enough, the American Lung Association reported in 2009 that the death rate for asthma was 1.1 for every 100,000, and that death rate was more prevalent in women than in females than in males. So when we're talking about this burden, we also have to relate that back to a financial burden. Financial burden as well as a burden on the quality of life within our communities. So in 2011, 4.1 million children in the United States suffered from an asthma exacerbation. Now that was either the initial insult or an indicator of the lack of asthma control in the children with asthma in the United States. Asthma is the third leading cause of hospitalization among children under 15 years, and interestingly in 2009, 774,000 emergency department visits were due to asthma. So we're talking about a huge cost burden, direct costs of approximately $50 billion in the United States annually, but also some indirect costs. And those indirect costs are very evident when we look at school absenteeism and work absenteeism, either from the disease process specifically or parents of asthmatic children missing work because they need to take care of their asthmatic child. So you can see that the statistics there are extraordinary. And again, this data highlights that the lack of overall control of asthma in the United States puts a huge burden not only on the healthcare system, but also on our patients and their lives. When we talk about hospital admissions, we have to look at the recidivism for our patients who have been discharged from the hospital. And we all know, we've heard multiple times already, that later this year the COPD readmission penalties will kick in. We haven't heard about asthma penalties, but if we took a peek at this, if we took a peek at this data, we would see that 12% of our asthmatic patients are readmitted within 30 days. Now, our index stays are at 347,404, and then 41,000 of those are readmitted within 30 days. So healthcare providers are obviously positioned very well to help our patients eliminate these readmissions, maybe even eliminate some of the original admissions if we can get in there, get the education that the patient needs, and help to take down some of these barriers associated with good self-control, self-management of the disease process. So let's start talking about disease management and the problem. It's no surprise that the asthma within the American population is fairly uncontrolled. We've seen that burden. But the uncontrolled asthma phenomenon is exacerbated by this lack of knowledge. With the lack of knowledge about the asthma itself and the medications, obviously our patients aren't going to be able to avoid triggers, properly take maintenance medications. There are a lot of misperceptions about asthma and medications. Before I joined the AARC and before I transitioned into education as a career path, I worked in inner city St. Louis at a very good children's hospital, and I worked in the emergency room of that inner city hospital. Excuse me. And as many of you, I'm sure, met a lot of parents with a lot of misperceptions about asthma and smoking, about when a child needed medications versus when to come to the ER, a lack of knowledge about environmental triggers. Without the support within the school network, without the support within the work network, and the inability to understand the information that we're providing, we're just precipitating that problem. So overall, poor health literacy is of course a huge issue. Another issue is that the education of asthmatics is the utilization of care. There are a lot of barriers to the utilization of health care, including poor information dissemination, unavailable continuing education specific to asthma for healthcare providers. You're here to learn about asthma, to learn about asthma self-management. Up until recently, there's been a fairly significant lack of continuing education programming for healthcare providers to learn more about asthma to help their patients. A lack of access to healthcare, of course, lack of health insurance, and then a shortage of healthcare providers in key areas. So, we have a huge issue here. Just by a show of hands, how many of you work in an emergency department and see patients utilizing the emergency department like a primary care facility, like a primary physician's office? Yeah, I see a lot of hands go up. Unfortunately, this is a very common phenomenon, and instead of seeing a physician in a physician's office, we see a lot of our patients utilizing the emergency room, or emergency department rather, as that primary care physician. I know that we saw at the inner city hospital in St. Louis, we saw a lot of kids come in because they didn't have a primary care physician, so that access really is a huge problem. And again, our patients' lack of understanding about medicines, the types, the schedules, the interactions. I don't know about you, but one of the challenging aspects that I experienced in the emergency department was a patient who would come in and I would ask, what inhalers are you taking? And the patient would say, well, I take my blue one whenever I feel ill. I take my pink one twice a day. Of course, I just showed my age by saying that they take a pink one, because I don't think the pink one exists anymore. But it was very important for the respiratory therapist to know the colors of the inhalers, because the patients didn't know the name or didn't understand the name or even the role of that medication. I'm sure that we all have stories about about a patient who would come in and tell you that they take their albuterol twice a day, but they take their Flovent whenever they were feeling bad. And of course that makes us all cringe. But this fundamental lack of understanding about those medicines, about how to stay well. In one of my experiences in rural Missouri, a parent was being educated about triggers and such, and her child had some significant triggers to weeds and grasses and things that grew in that area. And the mother started to cry, and when I asked her what was wrong, she said all these years she had been living next to a field in a farming community, and they didn't have air conditioning, so they left their windows open, and when the field was turned over, of course, all of those pollens and weeds and such were released, and so her child was consistently ill, and she said, if I had only known, if I had only understood what was making my child ill, I could have done a better job of keeping him away from those triggers. So this fundamental lack of understanding leads to obviously a significant burden and relapse and recidivism for asthma admissions. There was a study that I thought was really interesting from Zayas and McLean. They sponsored 4 town hall meetings and 4 focus groups in an urban minority community in western New York, and they focused on the participants' perception of asthma, how they cope with asthma, and how they learned about asthma. And in the study, the respondents said that poor communication with their physician and inadequate access to medical care were the two major barriers to asthma education. And the author quoted one participant as stating that he had learned more about asthma in the emergency department than from his physician. So it's again, just showcasing how our patients are learning, or not learning, rather, about their asthma. So I think I would be remiss if I didn't talk a little bit about health literacy. And health literacy, as we probably already know, is the degree to which individuals have the capacity to obtain, process, and understand basic health information. Now, it's not just about can the patient read. It's about whether or not the patient can take the information they are provided, whether it's written or verbal, internalize that information, make decisions based on that information, and navigate the health system. And there's a small typo on here. This was from Healthy People 2020 from the US DHHS. So health literacy is still, even though we've done a lot of work to improve health literacy within the United States, it's still a significant barrier to effective self-management for any chronic disease. And there are many things that affect health literacy. Reading level, obviously, but also education level and prior experience in healthcare. In children's hospitals, we call it the white coat syndrome, when a child freaks out whenever they see a healthcare provider in a white coat come into the room, because they associate that with pain, with a scary experience. And those prior experiences that we've had in healthcare are going to color how we look at future events. So if I've had an experience with a nurse, a respiratory therapist, a physician, a nurse practitioner that was not positive, I wasn't trusting of them, they steered me in the wrong direction, they didn't give me enough information, I'm going to look at other experiences with that type of professional in the same way. And that can really significantly affect whether or not our patients can trust us. And without that trust, there's no way that our patients are going to believe what we say and then take that information and hopefully use it to make a positive change in their lifestyle so that they can stay healthier and live a better quality life. Fear and anxiety also affect our patients' ability to understand what's going on. I know that in many of my experiences with both adult and pediatric patients, if I go into a room when my patient is very anxious, maybe has just been admitted into the hospital or just recovered from a significant exacerbation, those are not the times to try to educate our patients about their disease process. We want our patients to be calm and relaxed and open to talking to us rather than in a very anxious or fearful state. Again, it's not a good time to discuss anything with our patient at that point. And of course, culture and socioeconomic factors are also an issue. But you know, each of these barriers must be addressed on an individual basis. I would caution everyone to not stereotype our patients by gender, culture, age level, because even within that subdomain, that person is an individual, and they're going to have individual barriers. They may not have barriers that are stereotypical to that group of persons that we're trying to lump them in together. So highly individualized care is very, very important as we talk about asthma self-management. But the asthmatic person's health literacy, overall health literacy, does impact the level of success of any asthma education program. And educators in the healthcare environment can try to ensure that these persons receive the proper written materials and verbal instructions. But we do have to be very, very careful, because many of our written documents are at a level higher than the typical, than the average reading level. And depending on the source that you use, some say that we should be using materials written at the 4th grade reading level. Others identify the 6th grade reading level, so it depends on the source that you're using. But the challenge, regardless, is to make sure that we, as health educators, identify those persons at risk for low health literacy and tailor whatever program we're using to that individual's level of understanding to make it most effective. And so here are some problem areas, and I have a few words on here that we tend to throw around a lot. Well, are you taking your LABA? What's a LABA? You know, we talk about bronchodilation and we talk about asthma exacerbations, but to the majority of people, these words don't make sense. They're too big. They're too medical. They aren't words we use in a regular setting. So language, obviously, if our patient is an English as a second language speaker or a non-English speaking person, that's obviously an issue. Cultural awareness is necessary to make sure that we have appropriate communication. Reading, again, actual literacy, but also using pictures. How are we using, if we're trying to use pictures, are we using a universal picture, something that is not going to be misunderstood or misconstrued? Again, we need to avoid medical jargon as much as possible and accommodate any hearing or vision disabilities that our patient may be experiencing as well. So we talk an awful lot about poor health literacy, and I'm sure that any asthma self-management course you have attended talks a lot about this, and you're probably thinking to yourself, yeah, get on with it, let's move on. But it's important to address health literacy, specifically because it has such tangible consequences. It leads to a worsening disease process because our patients are unable to adhere to a medication regimen. If our patients don't truly understand what the medication does, why they need to take it, what time they need to take it, and really understand the rationale behind it, they're less likely to adhere to that regimen. You have to really internalize that information. Patients may not recognize when they feel bad. I know that I've seen a lot of people, typically adults, in the emergency department with a severe exacerbation, and you ask, why didn't you come in earlier? Why didn't you call your doctor when you started to feel badly? And the person says, well, I really didn't think it was that bad. So not recognizing these, not recognizing the triggers, the symptoms when they start to hit upon us. Lifestyle factors. We still have a great number of our asthmatic population that smoke. So there are a lot of factors here that are going to, based on poor health literacy, that are going to affect that disease process itself. Because our patients wait too long to come to us, they have more frequent hospitalizations, and the hospitalizations are typically longer. It takes longer to get them over that exacerbation, which of course leads to a higher cost of treatment, potential loss of employment because they're missing work because of their disease process, or because of their child's worsening or uncontrolled disease process. And medication errors because either they don't understand the directions or they're cognitively unable to follow those directions. And one of the stories that I've recently heard that illustrates the medication error problem is of a lady, an older lady who was sent home with her inhaler, her dry powder inhaler, that uses a capsule. And she came back to the emergency room 48 hours after discharge. Her respiratory therapist says, what are you doing here? I just discharged you 48 hours ago. She's very ill, she's short of breath, she's requiring oxygen. When she finally is able to discuss this, the therapist says, so tell me, what happened? They have a conversation. The therapist is having a hard time figuring out what happened, and he finally said, okay, ma'am, show me how you're using your dry powder inhaler. And come to find out, the gal was having a very difficult time getting the capsule out of the blister pack, and she was so frustrated with trying to put the capsule, the tiny capsule, into the dry powder inhaler that she would toss it into her coffee and drink it. And of course we know that the medication is not going to get where it needs to go. So those are some things that we have to consider as we're discharging our patients and providing them with the medication that they need. And the impact of health literacy on health care, poor health literacy on health care, is again tangible. Approximately 6% of our persons with low health literacy have 6% more hospital visits per year than those with adequate or high health literacy. These persons stay in the hospital 2 days longer on average, have fewer doctor visits a year, but use more resources per year. Again, that goes back to not recognizing signs and symptoms and waiting until the disease process is in an advanced state before coming to the hospital. Adhering less to medication regimen, and then ultimately having higher mean Medicare charges. So a lot of tangible consequences to that low health literacy. And there are physical barriers. So as we learn about patient education and as we reflect on how we talk with our patients, we're going to encounter barriers that we have to overcome. What prevents our patient from hearing our meaning, internalizing it, and applying it to their health condition? A person's physical condition can extensively influence his or her ability to pay attention or remember information and apply that information to their situation. So our patient who has an acute episode of hypoxemia, that's probably not the time to try to educate our patient. We have to make accommodations for those who have hearing or visual impairment, but also persons in pain, a person who is distracted, scared, angry, anxious, a person who has cognition issues, a person with memory loss. These physical barriers make our job exponentially more difficult. And sometimes, in these situations, it's most advantageous to come back later when that condition has resolved itself, if it can. Another situation that poses a great deal of challenge is pre-discharge. How many of us, show of hands, how many of us have been called 10 minutes before the patient walks out the door to come and do discharge education? And it's almost laughable. Because our patient is ready to go home. Their ride is here. It's time to go home. I'm not listening to my respiratory therapist. I'm packing up my clothes. I want to get out of the hospital. I want to make sure that, that my patient gets the information, hears the information, and applies it, and 10 minutes before discharge is not the time to do that. Now, a lack of support system can be significant. It can mean disaster even if the patient has the best of intentions. The patient may truly want to take good care of herself, but without someone who they can trust, they may not be able to remember to take medicines. They may not be able to find transportation back to the clinic. And of course, as you know, in the case of children, we have to make sure that the parents are willing to do what needs to be done to keep the child in good health. We can provide the best education on the planet, but if the patient can't afford medications, we're not going to get our desired results. And so sometimes one of the barriers that we have to work perhaps with our social work counterparts is trying to find appropriate funding for our patients to receive their medications. Or perhaps the expensive inhaler is not the inhaler to use. Maybe we need to scale back a little bit, grab a different inhaler that's cheaper to make it more likely that the patient is getting a medication that will help control his or her asthma. And then our environmental issues, our hospital environment and our home environment. In the hospital, it's preferable to have a quiet environment, but if the family's interrupting or the grandkids are running around the room or other healthcare professionals are in and out, that can significantly impact our ability to provide good education. And in the home, patients may be unable to conform to educational plans due to live-in relatives or limitations simply due to the type of dwelling, an apartment, living in an urban environment versus a rural environment, lots of different things. So addressing this issue, we know that patient education works, and the AHRQ has they funded a study that was published in the Annals of Internal Medicine in 2009 outlining why patient education is so important. Obviously, we know that they need a clear understanding. They need to know how and when to take meds. They need to know how and when to make follow-up appointments. And the great news is patients who get this education are 30% less likely to visit the ED or be readmitted. But what I want to stress is it's not so much that the patients have been in the presence of a healthcare provider who verbalizes this information, but patients who really get it, patients who understand this information are 30% less likely to visit the ED or be readmitted. And we want our patient to be an active part of their health care. There's a study from Adams, Smith, and Ruffin from 2001. It's an older study, but it found that a participatory style that involved giving asthma patients choices about, control over, and responsibility for their care is related to greater patient satisfaction with that care and increased likelihood that the patient is actually going to follow that plan. So we want the patient to have buy-in so that they accept that self-management plan, and they internalize it and adapt it into their lives. Now, the ideal asthma education program should be carefully planned with appropriate materials and structured over a certain period of time. That study that I just quoted from Adams, Smith, and Ruffin also identified that sessions greater than 20 minutes in length were better at conveying some of these information. So again, that 10 minutes post-discharge session, probably not the best opportunity to engage your patients. So when the patients do come back to us, we can develop sessions that can really improve their learning. Number one, with more focused healthcare visits. Instead of having a patient come to the clinic, come to our asthma session, come to the physician's office and say, okay, so how's things going? We're really going to focus. This time we're going to focus this healthcare visit on medication adherence. What is the medication? How are you using it? Show me your technique with that teach-back method. Show me your technique. We want to make sure that our communication is clear. And we want to make sure that our verbal, our written, and our nonverbal communication is all addressing the same issue. We don't want our nonverbal and our verbal to completely contradict each other. We want to make sure that we're delivering a consistent message from all healthcare providers. One of the biggest pieces to improve the learning is the follow-up. I think that over the years, perhaps healthcare has gotten a little lax in that follow-up piece, and now we're playing catch-up. Many of us have discharged patients over the years and just crossed our fingers that they didn't get readmitted. But in reality, what's going to improve that prevention of readmissions is to call up our patients, don't lose track of them, follow up with our patients, keep in contact with them, let them know that we're interested in how well they are, how well they're doing at home. Follow up with them, call them, how are we doing, how are your meds, is everything working? Make sure that the barriers that they may encounter in the home are identified and hopefully overcome. And then establishing a partnership for education. So again, we want to make sure that the follow-up and the relationship between the provider and the patient are strong. Okay, so before I launch into the asthma self-management piece, Reagan, if you could help me clear out the hands so that we can start over again. If you are currently working in an environment dedicated to asthma self-management, raise your hand. So you're actively participating in an asthma self-management program. Quite a few people. Fantastic. Great. When we're talking about asthma self-management, we have a definition of, we have a rationale as to why it's important. You know, the EPR3 has stated that it's an essential piece of providing patients with the skills necessary to control asthma. So let's first identify the source. Everyone should be familiar with the National Heart, Lung, and Blood Institute's Expert Panel Report, third version, that was released in 2007. And even though it seems to be a little bit of a dated document, it has not yet been updated, and the materials within the EPR3 are still very, very applicable to what we do. The EPR3 has been a mainstay in the effective management of acute and chronic asthma. And one of the 4 components of this EPR3 is effective self-management. Section 3, Component 2, all 73 pages of it, is dedicated to helping practitioners empower patients and families to manage asthma effectively at home. But according to the CDC, I have some good news and some bad news. Good news is that more than 8 in 10 children are taught how to recognize asthma symptoms, so we're doing better with that. The bad news is that less than 7 in 10 adults are taught how to recognize asthma symptoms. Shouldn't that be 10 out of 10 patients, adult and children? So our providers must be proficient in asthma education so that we can pass on that information to our patients to help them recognize their symptoms and effectively manage their disease process. So this box here, the key points box I have on the screen, that's directly from the EPR3, page 93. These are the pieces of education that the provider must have in order to deliver effective self-management education for asthmatics. And you can see in parentheses, each of those bullet points has evidence B. This is good evidence of why our providers have to be skilled in these areas to effectively educate our patients. So key components of a good asthma self-management program are listed here. The main goal, of course, to improve quality of care and patient outcomes. We talk a lot about reducing expenditures, and that's obviously a very good goal, but the evaluations of disease management programs should not be solely based on reducing expenditures. Emphasis on the overall benefits derived from disease management and improved quality of life really are our main goal. The guidelines that we have within the EPR3 that drive our asthma self-management programs represent a consensus in appropriate treatment and management strategies. So these peer-reviewed guidelines can help us standardize this care across the U.S. Our patients need accurate and relevant information to self-manage their disease process. So again, focus on increasing adherence based on that best available evidence. We really can't focus on assessment and reassessment enough. Patient outcomes are vastly important to constructing an individualized disease plan, and so using those scientifically based evaluations and altering, if necessary, the disease plan based on the outcomes of those evaluations is a vital component. And of course, we can't treat the disease without knowing all of the nuances. We have to understand our patients' comorbidities in addition to the primary disease so that we can focus on helping that individual patient overcome barriers and improve his or her quality of life. And then understanding our population served. Disease management programs should be developed to broadly assess all populations, but we also need to be able to specifically address the unique challenges of the underserved and vulnerable populations. Who comes to your clinic? Why are they there? What are their unique barriers, and how do you overcome those? We have to be prepared to make sure that all of those health disparities are addressed, or the asthma self-management program is not going to be successful. Now here comes the piece where respiratory therapists are specifically called out. Many times people may say, oh, well, my nurse is my asthma educator, my physician is my asthma educator, and Without a doubt, those professions are very qualified to do so. But in the EPR3, page 101, paragraph 2, if you would like to look it up, the EPR3 specifically identifies respiratory therapists as appropriate asthma self-managers, as appropriate asthma educators to teach the self-management programs. And they do a nice job of calling out the specific skills of the respiratory therapists and identifying our unique role in providing asthma education and our qualifications. So just in case you needed some proof that respiratory therapists are really as awesome as we say we are. So the EPR3 recommendations for education are pretty specific. The EPR3 specifically identifies that we provide information about pathophysiology of asthma, asthma management skills, how the patient can monitor him or herself, symptoms, peak flows, changes in breathing patterns, a written asthma action plan, regular assessment by a consistent clinician, and this is really important. How many people, by a show of hands, work in an academic health center where you have residents rotating in and out every month? Yeah, quite a few people. That means that the asthma clinic this month is staffed by your R1, Dr. Smith, and next month it's going to be staffed by your R2, Dr. Jones, and so each time the patient comes back, there's a different resident and perhaps even a different attending that the patient may see. So that regular assessment by a consistent clinician is important because we want to make sure that our patients are being seen over time by someone who knows that patient, knows their trigger, knows their plan, knows their barriers, and has helped them before. And of course, reinforcement of concept. Again, I can't stress enough the importance of the individualized plan for each patient. And for those of you who work in the asthma clinic on a regular basis, this is not news to you. Your patients may all have asthma, but they are very unique, and each has unique needs that we have to adapt to. So regardless of how you reach your patients, all of the components here are vital. The EPR really wants us to involve our patients in the decision-making when it is appropriate for them to do so. We all know from our basic psychology courses that if a patient is not invested in the disease management or the family isn't invested in the disease management, it's not going to be successful. So we as the patient have to take ownership of our disease process to really achieve long-term control. And this is obviously not just an asthmatic issue, but an issue faced by all patients with chronic disease processes. So written asthma action plans. Asthma action plans are tangible artifacts that can drastically improve communication and reduce confusion about managing symptoms. Patients don't want vague information. What they want is information that they can concisely address to make sure that they understand what to do in any given situation. Asthma exacerbations are emotionally distressing not only for the patient but also the family. So let's take some of that stress away from the patients and provide them with an explicit set of instructions on when and why to administer meds and call the doc. So a written asthma action plan would include not only daily management instructions, but also instructions for recognizing exacerbations and what to do when an exacerbation occurs. Should they up their dose of their inhaled corticosteroids? Should they take extra of their reliever medications? What do I do with a specific outcome measure? And most asthma action plans use the peak flow as the objective outcomes measure. So that's something our patient can do at home, and it's something they can easily adapt their plan to. And this is particularly recommended for patients who have moderate to severe persistent asthma, or persons who have had a history of severe exacerbations, or patients who we know are poorly controlled. Now, the sad part is that according to the CDC's latest statistics, people are not getting their asthma action plans. Less than 1 in 2 children get an asthma action plan, and less than 1 in 3 adults get an asthma action plan. So we are not doing a very good job of getting all of our asthmatics the plans that they need to manage their asthma. So show of hands, how many people discharge your asthmatic patients with an asthma action plan? Good. Very good. I love seeing all those hands go up. These are asthma action plans that I got off of the internet. I'll tell you that I just stole the images off the web. They come in all shapes and sizes. Some of them are multi-printed pieces of paper. Some are triplicate copies. If you go to the web and just type in asthma action plan, you'll get 100 asthma action plan examples that you can use. But we have to remember our patient literacy skills. So if you'll notice, one of the common pieces of all 3 of these action plans are the fact that they use the basic US stop sign design. Green means go, green means good, green means I'm doing a great job, my asthma's under control, life is good. Yellow means, whoa, slow down, my asthma's not doing so well, maybe I need to stop my activity, maybe I need to take my quick relief medicine, maybe I need to increase my dose of steroids, pardon me. And then red means stop. I am having an exacerbation, I need to call my doctor, I need to call the emergency room, I need to take my quick reliever. Lots of different things. The asthma action plans, the most popular ways to set this up is based on peak flow zones. Typically the green zone is over 80% of personal best peak flow. The yellow zone is between 50 and 80% of the personal best of the peak flow. And then the red zone is typically less than 50% of the personal best peak flow. So again, this plan is a great way for us to write out exactly what should be done at any given point in time and have this available. When I was working in asthma camps, we would send all of our kids home with this asthma action plan, and we would tell mom and dad to put it on the fridge, because that's the one place where everybody in the home goes. Everybody goes to the refrigerator at some point. So, is patient education effective? The short answer, yes. And here's some information from the EPR3, a few resources for you there. And randomized controlled trials have shown that the asthma action plan has reduced symptoms, fewer days of restricted activity, improvement in quality of life, and improved inhaled corticosteroid adherence as well. But we can't just provide training knowledge without skills training, how to use your inhalers, how to use the peak flow, because without the skills training we can improve knowledge, but that's not going to reduce hospitalizations, ED visits, unscheduled doctor's visits, or lost work days. Now it is important to understand that your asthma clinic may qualify for reimbursement. The AMA added CPT codes in 2006. There are 3 codes there. One code is for individualized training. Another code is for 2 to 4 patients of an education in an education system. In an education session, and then another code for 5 to 8 patients in an education session. But to qualify for this reimbursement, the program has to be recognized by a physician or a non-physician healthcare society or association. But program recognition, very important, does not guarantee reimbursable. The program, there are a few program bodies out there. Each is a little bit different in the program delivery, but all of them have the same key components. It's important to note that CMS does not pay for this, but private insurance might pay. One of those programs is the AARC's Asthma Self-Management Education Program, or ASME. This was started in 2009, and it's an AARC-sponsored recognition program for asthma education and training so that programs can become eligible for those reimbursement codes. So the minimum requirements of a program seeking ASME certification is that the program must have accepted patients for at least 6 months before the application, because the application wants to see outcomes of the program, successful outcomes, and it must meet or exceed all of the standards listed within the ASME certification. Once the certification is granted, the certificate is good for 3 years, and then the program would need to apply for recertification. And here is a list of all of these standards. I won't read them out to you, but I do want to show a couple of things. Note that numbers 7, 8, and 9 are all very specific toward the individualization of the asthma program to each patient. So again, really focusing on making sure that all of our programs are not only addressing a population, but making sure that each individual patient gets the specific care that their unique situation demands. And then numbers 10 and 11 are specifically looking at outcome measures. We don't want this nebulous program that may or may not produce any good effect. We want to know exactly what the outcome measures can be and how well that program is meeting those outcomes. Are we reducing physician visits? Are we reducing exacerbations? Are we improving compliance with inhaled corticosteroids? So in addition to the administrative pieces of this and the qualifications of the persons who are running the program, it's also important to see those outcomes and see how the patients can improve. And effective disease management programs have common themes. They're all very unique. They address different populations. They address different demographics. But 4 common themes include those measurable outcomes, focusing on that assessment, education, assessment cycle to identify gaps and address those gaps in knowledge. Individualized care, again, taking into account those comorbidities and making sure that the patient's entire well-being is taken into consideration. And then following up with post-discharge to prevent those readmissions on the back end. One of the ways that we can improve this is to help get respiratory therapists into the outpatient setting, and the AARC does have HR 2619 as a current bill out there. It's called the Medicare Respiratory Therapy Access Act, and it covers pulmonary self-management education for 5 different disease processes. Asthma is one of them, and these pictures are from Tuesday's visit to Capitol Hill in DC of the PAC team that went and lobbied for this. So if you wanted to throw in your support, if you haven't done so already, you can go to the website listed there, or you can also just go to the AARC's website and check out the main button there. So my take-home message for us all today is that asthma self-management is supported by evidence. It is an effective method to reducing asthma costs, improving patient outcomes, and improving quality of life. Identifying barriers to effective self-management is crucial to developing strategies to improve patient outcomes. Respiratory therapists are identified in established literature as appropriate educators for asthma self-management. We need to be out there within our populations, in the clinics, in the asthma camps, doing effective discharge planning and education. Recognition of an asthma program may qualify the program for reimbursement opportunities, and HR 2619 is an important adjunct to helping us get into the community, to help the patient, help the community, help us as a profession enhance asthma education so that our patients get the best quality care, easily accessible, stop using the emergency department as primary care facilities, and improving quality of life. These are my references, and I am happy to take any questions.
Well, thank you, Shawna. While you were doing your presentation, we did have several very good questions come in. These may not be in the order that they came in, but I'll try to take them in an order that maybe makes some clinical sense. So let's start in the hospital setting for that patient that has been seen in the emergency room or possibly hospitalized with an exacerbation. There was a question that came in, is that an appropriate time and venue to do asthma education?
So at the time of admission, it's a great time, if not to educate about the disease process, but to establish the baseline level of knowledge of the patient or the family. Obviously, if this is an adult patient with asthma, we're not going to make him or her talk until they are able to discuss this with us. We certainly don't want to throw them into another exacerbation just by quizzing them about their asthma, but at the same time, once they're able to talk, or once the family is able to concentrate, identify the gap. You know, when our patient is admitted or when they're brought to our emergency department, one of the first things that we do is say, okay, let's treat your symptoms, but one of the questions that I think we really need to be asking is, what brought you here? Why are you here? What happened before you came to my ER, before you came to my hospital, to put you in this state, and help understand what's going on, to figure out, you know, on the back end, how can I get them maybe some help at home. I worked with a gentleman in Southeast Missouri who did environmental assessments of homes, and one of the things that he found was this little gal had come in, you know, every 3 months. She was one of the, pardon the phrase, frequent flyers. Everybody knew her, and the family was hotlined because this child was admitted so often, and her asthma cleared up very, very quickly after admission. Come to find out, her home had a massive, massive infestation of mold. And once the family, who were really concerned about their child, once the family got the help that they needed to get rid of that mold, the child's asthma stopped flaring up, and she didn't have an exacerbation. She was well controlled. So if nothing else, it's an opportunity to find out what's going on with the patient and identify knowledge gaps.
Thank you, Shawna. So the next question kind of relates to, now you've actually sent that patient home and you've scheduled a follow-up visit. Obviously, it's tough to determine lung function during an exacerbation. So you want that patient to come back, be seen, post-discharge, have some pulmonary function a few weeks later. The question was pertaining to, would you ask a patient to withhold medications prior to a visit that was going to involve pulmonary function testing?
That's a tough question. If the purpose is to identify baseline pulmonary function of that patient, perhaps, but at the same time, the pulmonary function test might also be just useful for monitoring the disease process specifically and the level of control. So we may need to ask the patient to withhold a dose of their bronchodilator prior to the PFT. The hazard of that, of course, is that when we ask our patients to not take their inhalers, especially their maintenance medications, we may be putting them at risk for an exacerbation. But as far as bronchodilators, then yeah, you would ask them to not take the dose of bronchodilator prior to the pulmonary function test.
So the next two questions kind of are around general concepts of asthma education, sometimes not as much for the patient, but the community or those that are caregivers. So the first one, and there were a couple questions that kind of alluded to this, so I'll kind of paraphrase it. It was really around, from a pediatric standpoint, children that are actually in school or daycare for substantial numbers of hours and having access to their medication. How do you work with that if that becomes a barrier?
That can certainly be a barrier, and I know that there are schools out there who have policies that limit the child's ability to carry an inhaler on their person. We had to work, when I was in Missouri, we had to work a lot with this, with our school nurses, to educate the school system specifically on the need for the child to carry the inhaler and the need for rapid access to that inhaler with the child's condition, and maybe the pre-dosing with a bronchodilator prior to recess or physical education. Typically what we would do is obviously send a note from the physician, but also work with the school system to try to teach the school nurses. We had a couple of very successful school nurse programs where over the summer we would grab as many of the school nurses in the state as we could and run educational programs for them so that they would understand the necessity. But yeah, it's definitely a barrier, and it's one that we definitely need to make sure our physicians are writing very targeted notes to the school system stating the need for that inhaler, and working with school administrators on that policy.
And since we're getting close to being right up against the hour here, the final question is kind of more of a global question like that, and it came in here just as we were wrapping up. Do you recommend seeking information about significant other smoking around the asthmatic patient?
Are we talking about trying to figure out who in the family is smoking around the patient? Is that the question?
That appears to be the question. You know, be it a caregiver or a parent or a grandparent for a child, or potentially a significant other spouse of an adult asthmatic patient, I think is how it's geared.
Yeah, absolutely. You know, this is one of the opportunities that we have to really educate our families. We all know that obviously firsthand smoke is very, very bad. We know that secondhand smoke is very, very bad. That's not in debate. Now we're looking at thirdhand smoke. The parent who says, well, you know, I only smoke outside, and so, you know, my kid's not around it, or I don't smoke in the car. But then they come back into the home and they reek of smoke because it's stuck to their clothes. So we are very focused on making sure that the families understand that just because you don't smoke near them, you're still bringing in pieces of the smoking environment to the child, to the family, to the asthmatic patient. So definitely that third-hand smoke is an issue, and you know, the biggest problem, of course, is that our persons who smoke don't necessarily want to quit smoking. So it's an ongoing battle, but absolutely I use every opportunity to not nag necessarily about smoking cessation, but to constantly plug away at it. When you're ready to stop smoking, let's figure out a way to get you, you know, to minimize how much smoke is coming back to the child or to the adult asthmatic. You know, look at this environment, look at what you are doing to that person's well-being. So it's an ongoing battle, but yeah, I would absolutely advocate that that's a constant topic.
Well, thank you, Dr. Strickland. I think that is the brunt of the questions that we received in the chat window. So I want to thank you again for joining us today. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation.